We're now moving on to the next session, a commercialization one, new healthcare models and approaches to targeting metabesity and healthy longevity. And I'm going to throw the mic, San, to the moderator. San, please take it away.
Well, thanks, Thomas. And thank you, Jay, again, for a terrific session. I just love that. And we did end up on healthcare, and that's the topic we're going to take on in just a moment. I am really pumped about this session. We're not going to have nearly enough time because of the fascinating people involved. So let's get started. We are going to be talking about probably the biggest challenge, I believe, in achieving healthy longevity, which is our healthcare systems. And let's not be parochial by focusing only on the US system, but on systems across the globe, which largely share the same shortcomings. And it's an oversimplification to say that healthcare is broken. To be fair, in the US, we now see some progress in major healthcare providers reimbursing for fitness club memberships. And we're seeing a proliferation of web-based systems for preventing diabetes, achieving weight loss, and maintaining wellness. The National Health Service in the UK is modeling some very attractive integrated prevention approaches. But in general, healthcare is a long way from where it needs to go to implement the full range of changes required to increase health span. In our session today, we're bringing 3 experts and change agents in the healthcare field. They're highly diverse in their backgrounds and in the time zones in which they are coming to us. And as a bonus, their life stories or career stories are just off the charts in being fascinating. So I'm going to ask each of our 3 guests to first say a little bit about their careers and how they got to where they are now, then to give us their diagnoses of the leading disorders in our healthcare systems. And then finally, what they see as some solutions. So let's start with our earliest riser today, who would be Evelyne Bischof, who is in Shanghai, and a multilingual person who, and this is quite amazing that she speaks Chinese and other languages that make her a true globalist. So Evelyne, very appropriate that we would start with you.
Thank you so much. Thank you very much for this extremely kind introduction. And it's a pleasure, and I'm very humbled to be also among such magnificent speakers. So I think I'm the latest riser or earliest riser today morning. So right now in Shanghai, it's 9:48 p.m. and I'm very happy to connect already from home. So in terms of my path, I was indeed as an MD taking a little bit of an extraordinary path, and it was interesting, and for me personally, it was something that I valued very much and brought me to where I am, to be quite a global citizen and quite a global person. So I studied in Germany, where I come from. I finished my studies there and went for an internship first to China and then to the US. I was very fortunate to intern at Harvard Med School affiliated hospitals. So I was just stunned by the level of Brigham's, MGH, and so on. Then moved to New York, to Columbia, and after that, I decided to pursue residency and fellowship in Europe, in Switzerland. But I was always living between Switzerland and China. So I was basically living between those 2 continents and tried to somewhat combine the developments that are quite different in the healthcare systems and in the also the adaptation of the society on those healthcare progresses in China with massive speed, specifically in Shanghai, And in Switzerland, that is very robust and also on a different level, moving with a little bit of slower pace, but very, very horizontal and granular. So that's basically it. And for the past several years, I've been more and more engaged in longevity medicine. So coming from internal medicine, I'm an internal medicine specialist. Longevity medicine was something that was the next level of an AI-powered discipline. And it's still something that I combine. Longevity medicine, so the very much progressive discipline, and internal medicine still as a clinician.
You're on mute.
Exactly.
I'm sorry. Thanks, Esther. Feel free to go ahead into what you would see as a diagnosis of our conventional healthcare systems and their ailments, or maybe you would prefer to just emphasize what are the future approaches that you're attempting to make happen now.
Mm-hmm. So in terms of diagnosis, I think we can fairly base our estimations on both the statistics and number two on the development of the demographics that is coming. And I think that I share the opinion of many where I see age-related diseases in general as the diagnosis of the future. So there's a debate around classifying aging itself as a disease. There's much debate around it. I personally embrace it simply because it would make our work as a clinician so much easier and implement a lot of the innovations which you just mentioned and the future that is developing so fast, perhaps a little bit more translatable into the clinic. So we have a lot of age-related diseases that are actually impacting most of our patients at the moment. The demographics is going towards the golden age or the silver tsunami that as we see. And the age-related diseases are actually the top global burden. So cancer, CVDs, neurodegenerative diseases are those that are prevalent, most prevalent. And they are all age-related. And the biggest risk factor is age, not genetics, not anything else. And I think where the future lies is actually what longevity medicine is trying to achieve. It's really to implement the entire chain of the gerosciences, solutions that are AI-powered, with deep learning, transferring all the tools that the AI can bring, and then translation to the clinic, both in terms of diagnostics, so extreme precision diagnostics, and then hopefully also therapeutic approaches, but not so much towards therapies, but very much towards, hopefully at some point of time, prevention. So identifying risk factors, hopefully as early as at birth, of any comorbidities, and then mitigation of those and elimination of those to the ultimate goal of improving the performance of a patient or of a person, with the quality of life. And quality of life usually includes not suffering from age-related diseases.
Wonderful. And if you don't mind, I'll call you Eva. I believe that's what you go by typically. And that was a great summary. It will resonate with other things to come. I know that one tie that binds you and Esther is the interest in AI and large data. And we will now go to Esther, who we've been after since 2017 for our first conference. And I'm delighted that she's able to join us now. She is just the epitome of being a change agent in the healthcare field. She's been in on some of the major developments. She was in on 23andMe. She's an entrepreneur, a philanthropist, and first of all, a great thinker. So Esther, we're honored to have you, and do summarize what you've done in your amazing career.
Okay, so I'm a privileged white lady. My parents were both scientists. I grew up at the Institute for Advanced Study, and then I kind of abandoned the family, ivory tower, became a journalist and learned how to ask questions. Worked on Wall Street for a while, spent 25 years producing a newsletter about the emerging tech company. And one of the people I interviewed, and I want to tell this story, was a guy called Charlie Silver. He created the website Real Age. You're probably familiar with it. It's mostly focused on sort of social determinants of health. Personal, do you have a dog? Do you have a spouse? Are you happy? And then your BMI and stuff. And it asked all these questions, then it gave you your real age as opposed to your chronological age. And of course, what we're really focusing here is how can you keep your real age low? Charlie Silver ended up selling his company to Hearst, and they sold it to ShareCare. But the magic question is, to whom did he share his first company, the one before Real Age? And the answer, believe it or not, is Jiffy Lube. It was a car repair chain. Anyway, that sort of, long story short, that led to me asking, well, why are we spending so much time fixing things that shouldn't have been broken in the first place? And so to some extent, I would say a lot of this is not the healthcare system's problem. It's like asking, why does car repair cost so much? They should be providing seat belts and putting up traffic lights and making cars bigger and safer. And maybe they should, or maybe they shouldn't. But the reason we think of health as being so much better outside the US is not because they have better healthcare systems, but because they have better social care, social safety nets, child care, parental leave, education for all, much better maternal health care, which includes counseling. And so my aunt worked for the National Health Service in England as, originally it was called an almoner, then it was called a medico-social worker. She was a nice Catholic girl, but her job was taking care of unmarried moms. And when she died 15 or 20 years ago, a number of the kids whose mothers she had served showed up at the funeral. So my diagnosis, and what I'm doing now, I'm involved in a 10-year nonprofit project. I funded and founded a 10-year nonprofit project working in 5 US communities to try and help them create some of that. And I sort of don't really like social safety net, preventive care. What we're really talking about is the health equivalent of economic development. And we don't talk about poverty prevention. We talk about economic development or investment. And what we need to do is invest in health from the start, create this asset that helps you fight against the things that happen when you age, rather than rent it and spend on it. And at the end, you've rented your health by taking drugs and taking aspirin and never actually fixing your symptoms, but fixing your problem, but simply dealing with your symptoms. And the one that Evie, you didn't mention, but it's sort of like the adjuvant for everything, is diabetes. Things go better with Coke and they go worse with diabetes. So that's kind of my overall. But in these communities, we're not really working with the healthcare systems because it varies, but to some extent, they feel that their job is to provide free care. And frankly, I think that is their job, and their job may not be to improve the schools or improve housing or provide vacuum cleaners so that people don't get asthma. What our government could really do is could tax sugar, and it could subsidize childcare, and that would create a huge difference.
Well, Esther, what a great summary. And you've touched on some really key points. You truly are getting at the very roots of the problem, which go beyond just metabolism, but into the depths of our social structure, the loneliness, the social isolation, the health inequities. These are all very important challenges we have to face to really get at the root causes of our society and its health provision. But I also like that background. It looks like the underground, the London Underground.
Yep.
But I mean, you're great at making maps and helping to guide people. So that's, I think, a great metaphor for what you do. And we'll come back to you in a moment. We're going to have plenty of time for interchange between the three of you. I now want to turn to and we're working east. We were in the Midwest after being first in Shanghai. We're now coming to my friend Brendan Carr, who I guess you're now in Montreal, or are you in Halifax today?
Halifax.
Okay, well, you're even further east than we are right here in Harpers Ferry. But Brendan is a true change maker in the healthcare field. Obviously, he's been working within the Canadian system, another more or less nationalized system. And yet he himself has been frustrated and finding need to throw out the current restraints or constraints and to come up with a better system. So that is all about Brendan's kind of vision. And I can't do it justice. Brendan is a former Canadian naval officer. He tells a great story about and being on a very small frigate and in close quarters with a huge oncoming commercial ship. And I can't do it justice. So Brendan, take it from there. Describe your conversation with the bridge of the other ship.
That's a funny story. Yeah, it's probably anyway. Thank you very much, and it's really a great pleasure to be here with everybody. And it's an honor and a privilege, and so thank you so much. And I won't belabor it, but it's an interesting maybe commentary on paradigm. So I was the commanding officer of a Canadian naval ship, which is kind of one step below a U.S. Coast Guard vessel in the big scheme of things. And yeah, we were coming out of a traffic system, and there was an oncoming vessel who was kind of moving across our bow in a way that they shouldn't have been doing. And so, as a commanding officer of the Canadian naval vessel, I reached out to the captain of the other vessel and said, this is a Canadian warship. It's rally. I have you crossing my bow. Blah blah blah. What are your intentions? And with great apology, the captain altered his ship the other way so that he would open up the space. And half an hour later, when the fog finally cleared and we were going by each other, I literally was like a cork bobbing in the ocean, looking up at this massive vessel. And it was just, anyway, it was one of the funny kind of early memories of mine. The other early memory of though being in the military was around leadership. And I think when I joined that ship, it was a Sunday afternoon. And I walked onto I was 20 something years old, crew of about 12 people. It was a small vessel. I walked around the upper deck. Most of the crew were kind of milling about because it was a beautiful Sunday afternoon. We were getting ready to sail the next morning. There was on one of the guardrails, there was just a bunch of paint peeling off. So I went to the paint locker, picked up a wire brush, walked back over to the up railing, and I started just scrubbing the railing because I was taking off the paint that was peeling, intending just to kind of give it a quick polish up. And 15 minutes later, the entire crew were scrubbing the entire upper railing. And about an hour later, the whole railing had been painted. And it was one of my earliest real lessons of leadership, which was I didn't say a word to anybody. I simply acted in a way that I thought was most appropriate in the situation, and people followed suit. And so my passion really has been around trying to lead through. And from the military, I had the opportunity to go to medical school. I went to business school. And I've always been kind of really fascinated by this notion of system of healthcare and kind of why it achieves what it achieves and why it doesn't achieve what could be really amazing with the resources that we have, both from a human, personal, intellectual, and kind of financial point of view. My leadership interest, I guess I'll tell just two very brief stories. So when I was early in my career as an emergency physician, doing some work in our hospital around kind of quality improvement and things, I volunteered in my wife's high intensity exercise program. She's a physiotherapist that was doing cardiac rehab. And I would frequently meet patients in their rehab program 6 weeks after I had resuscitated them in the emergency department, who in the rehab program, we were now making available all kinds of, lifestyle information, healthy eating, healthy physical activity, and we were kind of trying to make them healthy. And that just made me kind of wonder about the paradigm where, as a hospital system, we really glorify heroism and acute care, rescuing people. We really didn't, put our money where our mouth is, around saying, how do we actually help people to understand and see their health as a personal value, as an asset, like they would something else, and how do we help them to retain that? And at the same time, we were seeing a lot of patients being transferred into our emergency department in the middle of the night, oftentimes from local nursing homes. And the last thing you really want to do is meet somebody like me in the middle of the night when you're in respiratory distress, because my goal is I'm going to do whatever I can to save you. And one of my colleagues and I started talking about the fact that we were seeing these patients, we had no idea who they are, what their goals of care were, whatever, and we were basically kind of doing what we were trained to do. So we did a simple study. We looked at 600 consecutive patients coming into our emergency department from local nursing homes. We looked at the resources that they use in the hospital, and we went backwards and looked at into their records in their nursing homes. And I mean, we found staggering results. Of the 600 patients, when we annualized it, we were spending about $8.5 million a year transporting patients into the hospital. And this was in a small community, like probably 300,000 or 400,000 people. About 60% of those people were getting advanced diagnostics, interventions, et cetera. And the most staggering statistic was when we went back into their nursing home and looked at their kind of clinical care record, 70% of them had a written goal of objective that was not to receive any advanced care. And we were failing those patients because we didn't have the ability in that moment to understand what that person kind of wanted for their care. And so when those things happened around the same time for me, it really kind of led me to being quite passionate about how do we create a system that is actually much more inclined towards what health is, what matters to individuals, and how we create a system that is more connected and works together. And I guess I jokingly say I have failed to do that in 3 provinces in Canada, but remain committed to sort of exploring it. And as Zan said, I have worked within the public system as a senior leader. I've been a CEO in British Columbia and Ontario and Nova Scotia. And I'm really actually excited about trying to now approach this problem from the perspective of like an entrepreneurial organization that is actually prepared to work with partners to sort of see what we can do about this.
Wonderful, Brendan. We want to come back to a little more detail about what you're now doing, but that was just terrific. And we do have some time to converse among ourselves and to take some questions. And let's take one from Annalise Young, who asked the very salient and relevant question. Given the epidemic of diabetes, and since we're discussing healthy longevity, could you speak to how we can mitigate the rise of childhood obesity and diabetes? And let's do that from within the context of a healthcare system. And that starts, of course, with infant and pediatric care. So what do we do? And Esther, you would get at the deep roots, education, and Brendan, you would certainly look at the standard clinical services. Eva, you're looking at AI and way of characterizing risk and all sorts of things. So let's talk about that. Would you like to start, Esther?
Yeah, I honestly, if you made me rely on the healthcare system, I'd turn them to outcomes-based payments, and then I'd have them go lobby the government again to tax sugar, to deal with our food supply. It's not fair to educate people to eat healthy and then keep bombarding them with advertising with things like toddler milk, which includes added sugar, with all these juices that are promoted to kids, sugary cereals. It's crazy. And the healthcare, it's not the healthcare system's moral failing. It's our government's moral failing, and it's our moral failing not to ask our government to, we're starting to do carbon trading and price the environmental costs of things back. But one is simply the food supply and the marketing. The other is obviously people's habits. And it's hard to resist food if you're depressed, and it's one of the few things that brings you pleasure. And that's an even broader thing. But in terms of specifically against obesity and diabetes, tax the stuff that produces it and then spend that money that's made off these taxes on, if you want, metformin and various other things. But it's really a problem of our culture. And we've got the metabolism of human beings. We've also got the metabolism of the food chain. And that metabolism is based on money, and it's based on making people eat stuff that fundamentally is not good for them and becoming addicted to it. So I mean, the healthcare system can try, and it can educate people, and it can give them good advice, but it's neither what they're made to do, nor is it what they are able to do.
Yeah. Well, a great point, that this is more than just about healthcare and what it can do and not do. But let's go to Eva, who is essentially an internist. So you probably don't see children in your practice so much, but what would you see as ways of addressing these root causes of childhood obesity and malnutrition, poor nutrition, let's say, obesity?
Yes, so I was just looking also at some of the debates and questions that are ongoing in the chat, and it's really fascinating. I'm an internist, but especially recently, I'm also exposed to more and more parents coming with their children and tackling also their health problems. And I can absolutely just, we are singing to a choir when I say, Esther, absolutely, it starts with the education, both at home and then unfortunately also outside. So I face that every single day as a clinician. We are not vocal enough, and there is absolutely no way for us to win against an industry that is fueled by top experts in marketing that will induce and plant and then fertilize an idea in people's head. I see that unfortunately even in the so-called smart foods or healthy foods, or how they call it now. So I'm re-educating patients, with hypercholesterolemia, that even the egg white is not actually the right thing to do. So things as basic as that are being people are being misinformed. So I think definitely public and the governance should have a stronger lobby to get credible people talking about what is actually the healthy lifestyle. That's number one. That's something that should be implemented. And I see a message also in the chat from my friend Professor Meyer, who mentioned there is a lot of debate about how much can you push someone to be healthy and have a healthy lifestyle. Where do we stop it, and where do we actually act so that we prevent developing, for example, childhood obesity, or then further on diabetes and so on. So that's something very, very difficult to say, and probably also something that is very much individualized. But if most of the diseases, including diabetes, have a physical and psychological component. When I see that the psychological one is really overweighting and taking over, and I can change the physical one, then this is something where I would intervene with medication. But of course, and I think most of my clinical friends will always try to delay this moment as much as possible. And where I see the future is definitely, hopefully, so I'm a very big protagonist of longevity medicine, which is healthy aging. And it starts not only in the childhood, it starts at birth, neonatology.
Right.
But until we get there, I think we also need to re-educate the parents and everybody else on how quick, how early intervention have to be in terms of a lifespan. So starting at the childhood. Yeah.
Thanks so much, Eva. That's very helpful. And Brendan, going to you in Halifax and as an executive in the healthcare business, what do you see as future approaches that are within the realm of the healthcare provider to address these early roots of metabolic disease and the complications of age-related diseases?
Yeah, thank you. I agree with everything that's been made, and this conversation is a both and conversation. So we, as Esther was saying, we absolutely need to have, I think, very intentional, deliberate, and strong, healthy public policy. I mean, without that, we cannot be successful. But my sense is that when I think about the healthcare system, and if I think about it in the traditional kind of pyramid diagram, with all of our acute care services at the top of the pyramid, and if I think about healthy public policy as the base of the pyramid, in many countries, we're doing both ends of the spectrum fairly well. I think what we don't do well, and where the health system needs to do a much better job, is we don't translate kind of those population type approaches to the individual in a way that is accessible. And I think about, so when I was working on Vancouver Island, we had an indigenous population that was 6 or about 7% of the population of the island. Most of them lived in remote communities. When we measured life expectancy, it took about 5 hours to drive from the south of Vancouver Island to the north of the island. And literally for every hour that you drove north, there was 1 hour of life expectancy lost. And it was for people that were living on the same island, who notionally in the Canadian system had access to the same services, and yet life expectancy was 5 years lower in the north of the island, largely in indigenous communities, than it was in the southern island. So it's more than just putting in place healthy public policies. We as a system do have to take some responsibility for trying to figure out how we can make this, in a more personalized way, information and understanding accessible to individuals, and we have to start where they are. And so I don't think that this is something that the health system can do alone. I think we actually need to do this through a partner ecosystem, because the interesting challenge is, on the one hand, we have to be able to do it at scale, and on the other hand, like large systems like the systems I've been working have been failing for decades now, because they think creating large structures as a response to scale is a solution. And in fact, it's not. Large structures are ineffective at creating change at a local level. So we need scalable structures that operate at a neighborhood level with the local assets and players in an ecosystem that have the best ability to have an impact on people's lives. And I think the other thing that I would add into this conversation is, and I'm absolutely catch myself in this all the time, I have to check myself on my paternal view of the world, where my job is to do something about lifestyle for the individual. My job actually has to be to try to help them kind of come to their best lifestyle and do what I can do around that by working with partners. And so I think it is truly a complex problem. And it goes way beyond the notion of medical complexity as we understand it. It really involves behavioral complexity, social complexity, and many other dimensions.
Can I just quickly respond to the nurse in the chat who said, I'm a nurse and I'm prohibited from talking to my patients about diet. I mean, that's certainly not what I'm recommending. They should, if you can tell people, that's great. But the extreme of this resignation that the healthcare system should do it all, and there's also diabetes is inevitable. People just, it's not a disease of aging. It's a disease of diet and time elapsed. I was talking to someone in one of my communities about diabetes, and he said, yes, it's really terrible. Our healthcare system just needs to offer more bariatric surgery. And I keep remembering that whenever I think about this issue. It's not the solution.
Oh, that's something that just also gave me a little bit of a heart attack.
Yeah.
Yes, it's very bad to have this, and I think there was a very nice comment also about, you know, at which point of time do we intervene with what we have, and does it really make sense also to find new targets? I think yes, I think we definitely need to develop still new therapeutic targets and solutions, and then we have all the tools towards that. But the best, of course, is to not wait to, as you mentioned at the beginning, to repair what has been, you know, damaged. And I've been asked a question in the chat also here to a little bit to speak, you know, on this contrast between the Asian way and the Western way. And what's the difference of, you know, tackling the health behavior? And indeed, there are some sublime things here in Asia, especially in China, where I live, where I see that some things are very natural that are potentially not occurring in Europe. So the early morning wake up at 5 a.m., 6 a.m., seeing the aged people, elderly people, you know, 80, 90, working out in parks, working out on very, very primitive, but built by the government, like working out places where they, you know, combine the social components. So they come together, they dance together, they work out together, or I see them alone. So for them, it's the morning routine. So again, education. Some, you know, at some point of time, like some of my teachers said, you know, a human is an animal of habits. So at some point of time, it will become your habit. If you implant yourself with good habits, this will be good. And so bottom line, in the Western countries, a lot of things have this high maintenance thing. We don't see, you know, on the street things that are easily accessible pretty much to everyone. It's so easy. And once it's there, people reach out for it, including children, including the elderly. So so I think that's something that the West can learn from the East. I'm a very big protagonist of China, so I'm very biased here. Of course, vice versa, but no, I hope that with this I was able to answer the question. So very good health behaviors here in Asia that definitely could be translated towards the West.
Well, Eva, I love that reference to the picture of elderly people in Shanghai early in the morning doing Tai Chi or dancing. Obviously, that involves physical exercise, but it also is addressing a big problem in the US, and that's social isolation and loneliness, which are drivers of metabolic disease. And so I think you're absolutely right. We've got a lot to learn from other cultures in how they address health and living. And that's such a great example. This actually relates to a point made in the chat about treating aging as a disease. And certainly we are not doing that. We are talking about age-related diseases and how we prevent those diseases. But we see healthy aging as a natural process. And we want to make that as long as possible, free of disease. And so that would be, I think, the tie that binds all of us in this community.
I couldn't agree more. And may I just make a very small last point, because Medan Veyoaf made a good point in the chat. Med schools are not teaching lifestyles interventions as a part of the curricula, indeed. And I hope this will change. So one of the things that, you know, at least the healthy longevity or longevity medicine group is trying to do now is to educate physicians and people. So there are now, even there is a longevity medicine course that is CME accredited, where we try to motivate physicians to learn what is longevity medicine, what are the differences between longevity medicine and functional medicine, how much based on data and science this is, and where we can see that lifestyle interventions are not only there for fun, but they are actually influencing our epigenetics, our the metabolic pathways, and they are physiologically and biologically active. That's just a mention.
Thank you, Eva. And I knew that this session would just fly right by. It's been terrific to have these three outstanding experts. In the time we have remaining, and roughly 2 or less minutes apiece, starting, Brendan, with you, what would be your sort of closing thoughts, your suggestions or your concerns, your diagnoses?
Well, I think the panel, I think we're talking all around the right stuff, and it's always amazing to me the threads that travel through these conversations that I think are really real. So here's the thing. From the perspective of a healthcare system, healthcare systems, our DNA is all about incrementalism and improving what we do today, not really rethinking, and saying, how do we do something different? So I think we have to get there by, a different design process. So, design thinking where we have the end users, clinicians, and other people actually at the table. And I don't think government-led systems can do that as a government-led system. I actually think that we have to create a different sandbox, and I think that we have to bring other players into that sandbox. And I think the other thing, particularly in the Canadian system, we see this notion of public and private as a very binary thing, and we see public as good and private as bad. And I just think that is really old, antiquated thinking. I think that there's a big difference between saying, how do we create the right kind of policy parameters around public-private partnerships to ensure that we're holding on to the public good, which is important in the Canadian system. But I think that there are blended models where we can take advantage of all kinds of value in the private sector that we need to integrate into the public sector. And I think that I think I'll stop there. There's lots more. I think that we need to look to I think about other parts of my life. So what happened in the personal banking industry a decade ago? What's happening around the real changes going on in my life related to environmental awareness? And none of the big paradigm changes that are going on in the world today, I don't think that they're being led by bureaucracies. They're actually being led by movements, by people coming together saying we need to actually see this in as a different and as a whole, and we need to be kind of galvanized around trying to advance this. Diabetes couldn't be a better example of that, where we need a different approach to this with all of the above. So I do think it's really through partnership and a different ecosystem that we're going to achieve the change.
Superb, Brendan. Thank you. Sure.
I'll be really brief and leave a minute for Eva. We need, as a society and as individuals, to start thinking longer term. We are so instant gratification focused in everything, and we spend all the time. We do not invest. We don't have enough purpose to think about the future. Addiction is basically a disease of short-term thinking, and everybody's addicts, whether it's for money or food or instant results. And they become that way because they lack long-term sense of agency and purpose. And I'll be on again this afternoon and talk some more. Over to Eva.
Looking forward to that. And Eva, over to you. Last words.
I think I'm not going to take too much of the time of the session anymore. I will just end up really with the vision that I hope that our further endeavors and continuous work as medical and public health and scientific world, we will be able to transform our understanding of the healthcare system to not to add more years to life, but to add more life to years.
I love that. What a great way to end this session. It's been terrific Thank you so much, Brenda, Esther, and Eva from across the globe about what is the biggest challenge, I think, in life sciences and healthcare, the healthcare system itself.